I welcome all our faculty for this Biotek knee symposium. And I'm going to go to the share screen mode now. Can you see the screen?
Yeah.
So today it's a knee symposium, and it's going to be for an hour from now onwards. And we have like 3 eminent speakers invited for this, and fourth one is me. Okay, there are 4-1. Okay, and the theme of the meeting is going to be about sports injury, mainly around the knee joint. So arthroscopy related procedures. So for which we have 4 talks. The first talk is going to be about meniscus. Second talk is going to be about high Tbl osteotomy. And third talk is about posterior cruciate ligament reconstruction. And fourth talk about Patellofemoral Instability, where it's going to be on Mpfl reconstruction. So I have pleasure to introduce all the 3 eminent faculties who are joining this meeting. And first is Mr. Angus Robertson. We call Mr. because of the FRCS degree in UK is called as Mr. And he is, I can say, he's my guru as well. He is a consultant in trauma and orthopedics in Cardiff Sports Orthopedics in the University of Wales Medical School. He is a consultant there and honorary senior lecturer. His main interest is in arthroscopic surgery of knee, shoulder, and other joints. And he got trained from Yorkshire, and he has been the representative for BOTA, and he has done fellowship from Royal Infirmary of Edinburgh, and also from Adidas Sports Medicine Centre in New Zealand, and in Nova Scotia in Halifax in Canada. With all this, he's been, for me, what I know from him is he's an excellent surgeon. His skills are extraordinary, that I've witnessed many times, and he's a very good teacher that I know about. He's going to tell about meniscus repair, current trends and techniques. Next is, I have pleasure introducing my good friend Dr. Vinod Kumar. He is from New Delhi, and is currently the director, professor, and head of the Department of Orthopedics. His special interest is in sports injury and arthroscopy. I know that he has done a lot of procedures. He's got many publications also. And he's attached to one of the famous college in India, which is Maulana Azad Medical College, New Delhi. And he's going to tell us about his new technique of Pcl Deconstruction, where he does augmentation. And also he uses peroneus longus graft. And he will explain his own techniques in his own way. That is going to be the second talk. And then next is going to be Dr. Manjunath Kodihally, who is going to tell about Patellofemoral Instability, and he is going to tell about all the Patellar Mpfl reconstruction procedures. And he is based in Bangalore. He is heading the arthroscopy, sports injury and joint replacement unit at Fortis Hospital in Bangalore. He has an MBBS from Mysore, MS from KMC, has done fellowship in joint replacement, arthroscopy and sports medicine in Paris, and he has been in shoulder arthroscopy in France and hip arthroscopy in Liverpool, shoulder surgery in Frankfurt, Germany. With all his experience, he is back in India doing all the arthroscopy procedure. I have pleasure to introduce you. And these are the 3 outside faculties, and I am going to give talk on Tbl osteotomy, which will be the second talk, which is a joint preservation talk. So with this, I invite Mr. or Dr. Angus Robertson to share his screen to tell us about his technique on meniscus repair, and also tell about what is his experience about it. Angus, are you ready to share your screen?
Yes, thanks, Subra. If you can unshare, then I'll jump on it.
Thank you. Yeah.
Right, thank you very much. So is my screen visible?
Not yet.
Yeah, okay. 2 seconds. We visible now?
Yeah.
Yes, we are able to see.
So thank you very much. Thank you for everyone for taking time on a Saturday to dial into the meeting, and thank you, Subra, for putting together an excellent program today. I've been asked to talk about meniscal repair techniques and outcomes. Now, clearly you could spend an entire meeting on this, so I will try and be brief and cover as much as I can, while covering some of the basics and maybe talking about some of the current controversies and issues around meniscal repair. So the first thing we're going to do on this talk is talk a little bit about the background of meniscal surgery, a little bit about meniscal function. We'll then move on to meniscal injury patterns, talk a little bit about the assessment of menisci, and then look at the various treatment options of meniscal pathology and have a little bit of look at outcomes. I'm not going to make this heavy on references because ultimately you can find references to support most things that you want to do, and ultimately they're there for everyone to look at. So the first thing to remember is we've actually come a long way. Back in the 1800s, James Bland Sutton basically said that the meniscus was a functionless remains of a leg muscle, was thought to be vestigial and was thought to be of no use. Now clearly we've hopefully moved on a bit from there, but even if you go back to McMurray himself, he recognised that meniscal tears, particularly in the outer vascular zones, did have the ability to heal. But what he also recommended is that unless you took out the whole meniscus at the time of surgery, it was an inappropriate operation. And that's only in the 1940s. So in the last 60, 70 years, we've come a long way in terms of the understanding of how important the menisci are. So what are the menisci? Well, obviously they are primary stabilizers within the knee, and they're particularly important if you have ligament injuries. They're important in load bearing and in shock absorption, but more importantly, perhaps they're important for load transmission. So they transmit the longitudinal forces which are coming down the knee and dissipate them as hoop stresses in the knee itself. So loss of your meniscus can significantly increase your joint surface forces and clearly result in early degeneration within the knee. They also are important and play an important role in lubrication within the knee and helping the synovial fluid motion around the knee itself. So let's have a quick look at the anatomy. I'm not going to go through the gross anatomy in detail, but it is important to recognize there are significant differences between the medial and lateral meniscus, and also very big differences in their injury patterns. Lateral meniscus is clearly significantly more mobile than the medial meniscus. The medial meniscus is somewhat larger and is more firmly attached to its meniscal attachments around the capsule. They both have attachments anterior and posteriorly, and attachments running anteriorly in the intermeniscal ligament between each other. The other important thing to remember is the popliteal hiatus at the back of the lateral meniscus, and it's very easy to miss little tears which are stemming from that popliteal hiatus if you're not careful and assume that they are just part of the hiatus. Clearly tears in that area can lead to quite a lot of meniscal instability and potentially mechanical symptoms and further damage to the meniscus. So it's important to recognize the differing anatomies of the two sides of the knee. It's also important to remember the difference between the medial compartment and the lateral compartment, in that the medial compartment has a concave tibial surface, whereas the lateral compartment has a convex tibial surface. And this is very important in terms of the importance of the menisci. So if you lose your lateral meniscus, you have significant point loading on the lateral side of the joint and very rapidly accelerating arthritis, whereas on the medial side of the joint, you can tolerate a little bit more meniscal loss without loss of load sharing function. So it's important to recognize the difference in the two sides of the knee. I think one of the most important pictures really is on the left hand side of the screen as I'm looking at it. If you learn this part of the anatomy and the blood supply, then you really understand the fundamentals of what you should be doing in terms of meniscal injury. So the meniscus is made up of these circumferential collagen fibers, and they're really the important ones which dissipate the forces. So if you get significant disruption of those circumferential fibers from big radial tears or from root avulsions, then the meniscus will cease to function. You'll end up with meniscal extrusion, increased joint loading, and potential accelerated degeneration. You then have these radial tie fibers which tie these fibers together, and then on the surface of the meniscus you have a random collagen fiber network. As I say, the menisci are strongly attached at the front and the back of the knees, And it's important to learn these insertions, and if you're going to be doing any form of meniscal root repairs. They are quite complex, and they're not intuitive, so you do need to spend a little bit of time. And I think two of the most useful diagrams I've seen is from Leprard, and they're on the right side of the screen here, which gives you some estimates of where the insertions are. Thankfully, in most injuries, there is some remnant of the insertions, so you can use that to guide you. And I think sometimes it's more useful to use remaining anatomy to guide you, rather than depend on measurements, which may vary from patient to patient and may be difficult to measure in an arthroscopic situation. So base your surgery on the patient, not on some measurement from a paper. That's a pretty good lesson for ligament reconstruction and everything else. The other thing to remember is it's only the periphery of the meniscus which is vascular. It would be nice to think that certain people had more vascular menisci than the other, but unfortunately by the age of 10, most people's menisci resemble the adult meniscus. So only the outside 25% of the lateral meniscus and up to 30% of the medial meniscus is vascular. And clearly you need that vascularity to heal the meniscal tissue. And we can raise the issue of repair of radial tears, where you're repairing avascular areas, maybe a little bit later on in the talk. Obviously, the overall blood supply comes to the medial and lateral geniculate arteries and a perimeniscular capillary plexus around the knee. It's important to remember that at the popliteal hiatus, the vascular and that for much of the meniscus, nutrition is by diffusion. It's also important to remember that meniscus isn't just a static stabilizing structure, it also has proprioceptive and sensory functions, particularly at the anterior and posterior horns, and meniscal loss does give people that sensation that the knee is loose or not quite right or unstable. It's something you'll often hear patients complaining of, and a bit like losing your ACL, losing meniscal proprioception is quite important in terms of feeling that loss of knee function. So again, I'm not going to teach my grandmother to suck eggs, but everyone listening to this talk, I'm sure, will be aware of the clinical findings and history associated with meniscal pathology. But what I would say is just always have a high index of suspicion, because not every patient presents in an absolute classic manner. The typical things of medial joint line tenderness, effusions, positive McMurray's tests and so on will happen in some people, but it's not always universal. So it is important to have an index of suspicion. Just whilst we're on McMurray's tests, I always like to just throw up this one, which actually throws up the original description of McMurray's test, which was back in 1942. Because a lot of people talk about a McMurray's test being positive when you get pain through rotation of the tibia on the femur, but it's quite clear in his description that it is actually a mechanical description, not a pain description. So that's just for interest and historical reference. I guess most of us would look for a combination of pain or tenderness when doing McMurray's test. Clearly, x-rays for the most part are not particularly helpful in dealing with meniscal pathology, and the primary imaging modality should be an MRI scan. Obviously, high quality MRI scan is important, and obviously reading your own scans is important, as well as making sure that you've got a good friendly radiologist who can read the scans accurately for you. It's important so that you can plan surgery appropriately. It's important you're looking for things like meniscal cysts and also looking for secondary pathology. The classic is the sort of middle-aged to more elderly person with a medial compartment degeneration and a meniscal tear who has a chronic PCL injury. So if you don't go looking for other pathology, you'll miss important things which you may have to address at the time of surgery. So there's a few sort of classic descriptions of meniscal tears. We're going to go through them sort of bit by bit as the talk goes on. First one is the classic sort of longitudinal circumferential type tear. There are a couple of special examples of this, the ramp lesion and the bucket handle tear. And essentially, they're not particularly special in that the ramp lesion is just the longitudinal tear associated with ACLs in the back of the knee. And bucket handle tears are obviously just a longitudinal tear that's decided to displace itself and cause locking within the knee. So they're just variations on that longitudinal pattern. You then have oblique and radial tears. The radial tears and the oblique tears are particularly problematic around the roots, because if they occur within a centimetre or so of the root, then they can lead to complete loss of meniscal function. So it's important to look for those. And then you have your degenerate and your horizontal tears, which can be a sort of variety of patterns, really, obviously more in the elderly patient rather than the younger patient, and can often be associated with meniscal cysts and often with some degenerative change within the joint itself, which is going to influence the prognosis for the patient and may well influence your decision in terms of repairing or resecting meniscal tissue. So there's just a picture with a few examples. There's a bit of a displacement, partial bucket top left, a bit of a degenerate tear bottom left, small radial tear on the right, and a bucket handle tear bottom on the right. So any of you have done, I'm sure many of you have done a lot of arthroscopy and you'd all recognize those sorts of patterns. But the first thing you really need to decide when you're going to manage meniscal pathology is which of these categories the patient's going to fall into. Do you work on simply rehabilitating them, and maybe in the more degenerate, more elderly patient? Do you look at resections? Are you looking to repair, or are you looking at some form of replacement, whether that be with a synthetic meniscus or with some form of meniscal transplant? Again, we don't really have a lot of time to go into allografts and so on, transplants, but I will briefly touch on it at the end of the talk. So when you're looking whether or not to repair a meniscus, what are the kind of things which should be going into your head? Well, firstly, you need to obviously assess the patient properly, both from the point of view of the patient and the tear, ideally with MRI scan beforehand, but you also need to obviously do a thorough assessment when you get into the knee itself. It's important to choose the correct patient. Patients with high BMIs, patient with degenerate tears, patients with chronic meniscal tears and articular degeneration are not particularly good candidates for meniscal repair, and in many cases we're better served by one operation and a resection rather than a repair. Clearly, the sooner you can get patients in, the better. Menisci don't like being crushed between the joint surfaces, and therefore acute tears will tend to do better than the chronic tears. It's important that it's done in the right venue, so you've got the right surgeon who understands the equipment, understands the tear, has a number of techniques that they can use to repair the meniscus, and you need to have a correct, reproducible and safe. Obviously, in terms of the tear itself, ideally an acute tear, it should be, smaller tears will tend to do better, more peripheral tears will tend to do better. Those with associated ligament injuries will often do better than those without. The longitudinal tears, because they tend to not disrupt those circumferential fibers, will tend to do better, whereas radial and horizontal tears, it is questionable whether you should be repairing them, and there's a whole debate to be had about that. There's papers supporting radial and horizontal repairs, and in some circumstances I would repair the outer portion of a radial tear. I wouldn't repair the white on white portion of it personally. The horizontal tears, again, occasionally they do merit repairing. In many cases doing that, you worry about persistence of meniscal cysts. So there's a debate to be had about those, but I think most people would say that a vascular, certainly a vascular or a vascular to avascular junction longitudinal tear should be repaired. It's then important that you get the correct rehabilitation, correct weight bearing and correct bracing afterwards. And again, everyone will have their preferences on that in that respect. So if we look firstly briefly at meniscal resection, just to remind ourselves of the principles that we should be adhering to. The first thing is that we should only really be trying to stabilize any unstable meniscal tissue. We shouldn't be taking out any more than absolutely necessary. If we're decompressing cysts, which we should probably do for patient symptom relief, we should try and keep as much meniscal tissue, so only taking out one leaf of the horizontal tear, which is often associated with that cyst. We should always aim to maintain meniscal function as much as possible, and should be really careful around the popliteal hiatus and around the anterior and posterior horns of the meniscus. And perhaps more importantly than all that, we should make sure we protect the joint surfaces. Ultimately, the reason we're trying to repair a meniscus is to try and stop damage to the articular surface. And if we go in with our shavers, our punches, or whatever it is, and cause significant articular damage, then we've negated the whole point of doing a meniscal resection. So it is important that it's done carefully and that it's done with due attention to the joint surfaces. And that can be aided by things like putting the portals in the right place. It can be aided by pie crusting the MCL. It can be aided by using posterior portals and so on. So it's important that you protect the articular surface. So again, there's a million ways that you can take a meniscus out, and it all depends on the quality of the meniscus, the toughness of the meniscus and the patient itself. Clearly, if you've got degenerate old meniscus, it tends to go up a shaver quite well. If you've got young patient meniscus, it tends to not do that, and therefore you tend to have to use punches. I would severely warn people against the use of a knife. Certainly one of my early bosses showed me how to take out a bucket handle tear with an arthroscopy blade, and it promptly broke within the knee. and then spent an enjoyable 20 minutes trying to rescue this blade from the knee. So I'd be very careful about using a knife. It's not particularly advisable. I would say it's helpful to have punches with a variety of angles on them, a variety of curves, so that you can make a good resection. Okay, so what are your options? Well, the great thing is technology is always advancing, so you've got a million different options of what you can do, whether that be a more sort of an outside-in type repair, an inside-out type repair, an all-inside, or some combination. There's also the option of using adjuncts such as PRP around the repairs, blood clots, microfractures around the knee in order to try and produce a vascular environment where the tear is more likely to heal. Again, in a short talk like this, there's no room to go through those, but I think they're all factors to be aware of and make your own decision based on the literature and your understanding of the literature on those adjuncts to meniscal repairs. The kit on the bottom right is a meniscal mender set. There's a lot of different ones. This happens to be a Smith & Nephew one, but it doesn't really matter. It's quite important to have some sort of device like that to be able to get good repairs in the anterior horn of the meniscus. So look around for a kit which works for you. So the steps in the meniscal repair: firstly, you should assess the repair. You then need to prepare the meniscus by freshening the edges, making sure that you get good vascularity, trying to reduce the tear as best you can, and then produce a repair, and whichever device or technique you particularly wish to use. So I've used the medial meniscus as an example, and this is just an example of what I tend to do in each area of the meniscus. Obviously, lateral meniscus very similar. So what I've put as zone 1 really, which is a posterior root tear. So if you have a posterior root avulsion or a tear, then I would tend to use a trans-tibial root repair, which I'll cover later on. In and around the posterior horn, which is where that sort of ramp type lesion would be, obviously after an ACL injury, then you've got the option of either doing an all-inside technique, and sometimes you'd need to use the posterior medial portal to freshen it, or a ramp type repair, and again we'll cover that a little bit later on. Around the sort of avascular zone, what I've put here is zone 3. Most of those would end up getting resected to a stable rim. I think repairing them there is being done, but I'm a little uncomfortable with it in an avascular area. I think laterally in the zone 4, I think in that sort of situation you can usually get away with an all-inside repair using the lateral portal to access it. In zone 5, you're in a bit of trouble trying to get it at any angle really. So in these sorts of situations, a meniscal mender if you've got any questions, can you put them in the chat, because you need to mute yourself. Thanks. And then in zone 6, which is at the front, I would tend to use a trans-tibial repair or use an anchor. And obviously, if you're doing meniscal transplants, you need to be comfortable with putting in tunnels and at the front and the back of the meniscus. So ramp lesion, what's the fuss all about? Well, I'm not sure really. I think ramp lesions obviously they happen. It is just a longitudinal tear. There's obviously a lot of mileage in people talking about them and in companies selling equipment to repair them, and therefore they've become quite a talking point. But what I would argue is if you assess the knee properly, you should always look into the back of the knee anyway, through the notch, and ideally right through the notch for the lateral side of the knee, and therefore you'll pick up these small tears that you might not see from the front. Now, a lot of them can be repaired with standard all-inside techniques and therefore don't need any additional sort of high-tech equipment. However, for some of them you will need to make a posterior medial portal, and that's where you need to have techniques such as those who are also doing shoulder surgery would have, because essentially it's pretty much a labral repair as you would do in the shoulder. But obviously you need to be comfortable in those situations with passing sutures and suture passage devices. So the question is, what are the outcomes of meniscal repair? Well, again, there's a whole heap of literature out there, and essentially, if you've got a good wind behind your back, and if you've got a peripheral tear and it's got good vascularity in a younger patient, you should be up at the sort of 90% mark in terms of successful outcomes. And a lot of the literature will show that. Clearly, as the knee becomes more degenerate, the failure rates will tend to drop off, and therefore I'm always slightly nervous when people talk about absolute figures for success for meniscal repairs, because there's so many variables in terms of the tear, the patient, and the technique that you're using. So what I struggled with is any evidence for healing of avascular meniscus, but again, that's a controversial area, and I'm sure other people would have other views on that. But I think clearly, if you stretch the boundaries, then your outcomes are likely to deteriorate potentially. So the next sort of newish kid on the block, I guess, although they were first described back in the 1990s, is the meniscal root tears. And I think this is where recognizing them and having the appropriate treatment options to treat them is increasingly important, because they are potentially catastrophic to the knee as they completely defunction the meniscus. So the definition of them is they're either a radial tear, which is less than a centimetre from the attachment, or an avulsion. They're said to be around in 7 to 9% of arthroscopies, usually in association with trauma in the younger patient, and often in association with an ACL injury. And they can also occur in the degenerate knee as well. Most of them tend to be medial. I've got the figures wrong. Most of them tend to be medial, but you also do get lateral in a third, and medial in 2/3. If you're interested in classifications and remembering classifications, then Laprade has a classification for meniscal root repairs. I personally am not a great one for classifications. I tend to treat what I see in front of me rather than trying to classify everything. I appreciate if you're involved in research, that's a different matter. So the risk of these tears is early onset OA and meniscal extrusion. So clearly, if there is the rest of the knee is in good condition, if the patient is a suitable patient, then a repair is a suitable way forward. And there's two main techniques for this. Firstly, a suture anchor technique, which I've never personally used, and the trans-tibial pull-out technique, which I have used on a number of occasions. So the first thing is the table on the right gives you some idea of decision making. In the acute sort of traumatic situation, unless there's any contraindications, I think in most cases you should try and go ahead and repair. In the more chronic situation where there is significant degeneration, then avoiding repair is probably going to be more successful. The other thing to look at is the alignment as well, and you know, you've got to decide whether you feel osteotomies and stuff are helpful in this situation or not. And again, that's not really something we can discuss today. So again, in very simple terms, because obviously the easiest way to teach someone to do a procedure is to do it with them. But in very simple terms, what you do is take a meniscal device. This happens to be an Arthrex one, but there are other ones out on the market, and you pass a suture through the meniscus. It's quite helpful to make a cinch stitch so it doesn't pull out of the meniscus. And then once you've got your sutures through the meniscus, and I usually use 1 or 2 sutures, then you can pull them down the tunnel that you've drilled, ideally using something like a flip cutter, as you can see on the left hand slide here, so that you've got a fresh area for the meniscus to bed down into. So the stages essentially are to drill the tunnel using your flip cutter. Usually a 6mm is adequate for this, making sure you're at the insertion, freshening up the surface. You don't really need to drill a socket, but you should drill a sort of shallow groove so that you've got something for the meniscus to bed down into. And then retrieve your sutures, and that can either be done with a nitinol wire, as is shown on the right hand side here, or you can use something like a fibre stick up the tunnel as well. The technique shows using a Sublok C as the anchor on the front of the tibia. You can just tie your sutures over a button, and that's absolutely fine. Again, the literature's out there, there's plenty of it. The results from root repairs, again, if you choose your patient carefully, young, fit, healthy patient, you can make a significant difference. I'm somewhat suspicious because although we all know that root tears can result in accelerated arthritis, you've got papers with 2 to 3 years follow-up who's saying that they can detect an appreciable difference at that point between repairing a root and not repairing a root. For me, that stretches credibility a little bit, but you know, read the papers and make your own mind up. I think you know, without long-term follow-up, you can't be 100% sure. I mentioned meniscal replacement purely because obviously there were or are devices on the market for doing it. We did try them for partial meniscal tears and so on. I'm not convinced of their efficacy personally, and therefore I've personally abandoned them, but that's just there for completion. That's just an example of me putting one in. It's a few years old now. And then the final option, which has been done for a long time, is very well recognised and can be very successful in the right patient, is meniscal transplant with or without osteotomy. And it's perhaps surprising that it's not more widely used. And I suspect the reason it's not more widely used is trying to identify the appropriate patient, because the appropriate patient really is somebody who's had a complete meniscectomy, particularly a lateral meniscus, and has no damage to the joint surface. Well, most of those patients are asymptomatic, and therefore operating on asymptomatic patients on the off chance of making them better is an interesting ethical point. So I think most patients I would tend to choose would be in that situation, but would be getting some mild symptoms, but without significant degenerative change. Again, there's just a few pictures of meniscal transplantation, again, perhaps beyond the remit of the talk today. So what are the outcomes of meniscal transplant? Again, there are plenty of papers out there for many, many years showing that it can theoretically reduce the long-term risk of arthritis, and that it can, in the short term, improve patients' function. And certainly in my experience, the patients I've treated, they do feel significantly better. Their knees don't have that unstable feeling, that kind of empty feeling that you often have in a completely meniscectomized knee. Again, a talk about when to use them, when not to use them, is probably beyond the remit of this talk. So it has been, appreciate, a little bit of a gallop through in terms of trying to keep to time and actually making sure that we've got time for a few questions, to discuss a few questions. But I think it is important that everyone should be in the mindset of trying to preserve meniscal tissue as much as possible, understand the pros and cons of meniscal repair, but also be wary of not over treating in people and not over resecting menisci. Certainly on the basis of recent ESCA guidelines, the number of arthroscopies and resections of degenerate menisci in Europe have dropped fairly significantly. And I certainly think for those more degenerate tears, then a period of rehabilitation, activity modification, analgesia is almost certainly the best starting point, and that surgery should only be reserved for failure of treatment or significant mechanical symptoms. So let me have a look in if you have got any questions on that, let's have a look in the chat, see if I can work this. So yeah, so nothing just yet. Does anyone any participants have any questions or anything or any challenges for anything I've said? It'd be interesting to debate those.
Thank you, Angus. I think there is one question in the QA box.
Yep.
What size anchor do you use for the root?
So for the root tears, I don't use an anchor because I think it's pretty fiddly to get to it. It's technically difficult, and actually you always worry about the pull-out strength and so on. I tend to use the technique where you essentially freshen up the insertion of the root. I would then pass a couple of sutures through with a couple of cinch stitches through using a knee scorpion. I would then retrieve them down the tunnel that I've drilled, and then I personally would tie them over an endo button or any form of small button. To be honest, the endo button is just an easy one to use over the front of the tibia, rather than using an additional anchor such as is in the original Arthrex technique describing that. So in answer to the question, I don't use it. If I was doing an anterior horn tear, then in some occasions, I've only done it a couple of times, but I might well use an anchor. And in that situation, I would have used a screw-in double-loaded bioabsorbable anchor. But again, it's easier in some ways to use a tunnel even anteriorly. So I've only done it a couple of times, but it is described.
Are there any more questions? Do you have any questions, Vinod or Manjunath? Anything to add up?
I think it's a nice comprehensive talk. Thank you.
Angus, I have one question.
Yep.
Sometimes we find difficult to access medial side, and we do pike resting and we get it opened up. Yeah.
Yep.
So my medial side is not a big issue most of the time. How will you manage the lateral side if it is a tight knee?
Well, it's a bit more difficult, isn't it? It's exceptionally more difficult. So what I would do is have a low threshold for making a posterolateral portal, and try and get, if you had to get in right into the back, certainly for preparation, you can use that. Clearly, it's difficult to do a repair through that. It depends where the tear is. If the tear is right on the meniscular capsular junction, then you can potentially access it through a posterolateral portal, viewing through the notch. If it's more anterior than that, then yeah, it's really difficult to get to. That's where you fall back on your rule of not doing any articular damage before you try and repair the meniscus. I don't know if any of the other panel have any sort of hints and tips for getting into the posterolateral corner when you've got a tight knee.
Yes, yeah.
I had a case where a patient had a root tear of the meniscus along with ONE. So I had a doubt whether to do, because some people with ONE, whether to go with the H2O or with the root tear of the meniscus, which is more of conservative. So can we go ahead and do both at the same sitting? Is it possible? Or I got away with the case doing the root repair of the meniscus, and after 4 to 6 months, patient had some like pain improvement. She was doing better. So I thought I'll keep this H2O at the later part.
I think it's a difficult one, isn't it? Because the reason you're doing the repair is to prevent them getting arthritis. So if they've already got established osteoarthritis, it would strike me that there's no point in doing the repair. And I think the problem is, there's lots of things which say, there's a high prevalence of these things in osteoarthritic knees. Well, it's probably part of the consequences of osteoarthritis. So, it's a different population, isn't it, to that population who's a young patient who's avulsed it or torn it, and therefore, I don't think if they've got established arthritis, I worry about the logistic or the common sense of doing it. If they've got alignment issues, well, then I think your osteotomy is a better option, to be honest with you.
Fine. Thank you.
I don't know what the others think. So, Vinod, do you have any thoughts on that one?
Oh, I think I agree. I agree on this. Once there is an advanced OA, then probably it doesn't serve the purpose by doing repair, because loss is already there.
Okay.
So I fully agree, then it doesn't make sense. But I have one query to Angus about these root repairs with extrusion of the meniscus, that that this meniscus is extruded. So once we try to repair, up to what extent we should try to release and make the extrusion back to the normal anatomical position, because sometimes it's very difficult in chronic situation. So are your some tricks, or what is your concept? Means you believe that it should be released and reduced back, and then you should fix, or you can take the leverage that you just fix in a same position?
I think it's a difficult one, isn't it, as you say, because already once you've got, it's like a bucket handle tear in some ways. Once you've got plastic deformation in the meniscus, you're never going to make it the meniscus it was before the injury, and therefore you've just got to do what you can do. I think if you think that there's a lot of extrusion, I think the first key is to make sure that you get the insertion absolutely right in terms of where you're going to put the meniscus. And then perhaps, if anything, you want to probably slightly over tighten it to try and pull it back in. But I think once it's plastically deformed, I think it's difficult. And that's where you go right back to the beginning about proper patient selection, getting acute injuries, picking them up early, not leaving. Because often if it happens with an ACL or a multi-ligament or something, if you get in and operate on them in a reasonable time, and I'm not talking about rushing in within a few days, I'm saying once the knee's reached homeostasis, then you're probably going to be able to restore more normal function and reduce extrusion. If you leave it 6 months, a year and a half, then I think you're right. I think you never get it back to where you want to go. And I don't think there's any real tricks once it's plastically deformed, because the basic structure is gone of the meniscus.
Okay, thank you.
One other quick question about mismatch of allograft meniscal size in the patient. How do you select the correct size from allograft? Again, it's about pre-op planning. So we obviously do MRI scans pre-op. You check the size of the tibial plateau. You can actually do it. There is evidence you can do it from an X-ray, but I would tend to do an MRI scan, and then you measure the dimensions on the MRI scan. You send it off to the company. You wait until an allograft of the correct size is available, and then you go with that. And even then, you can get away with a millimeter or two, but it's important to try and match the graft to the patient. Clearly, you can cut them down a little bit, but ideally, you want to get the right size graft in the first place.
This is a question on about centralization, is it?
Yeah.
Yeah. I'm going to cover a little bit on that during my talk.
Okay. Oh, thank you. Thank you.
But I'm not very fancy about that one.
Okay.
I'll just cover it in 1 or 2 slides about that.
Yeah.
Are there any more questions? If there are none, shall I proceed to my talk?
Please.
Are you able to see my screen?
Yes.
Okay. Thank you, everyone. So my talk is going to be on high Tbl osteotomy, where we are going towards the joint preservation than joint replacement. So we all know the meniscus root importance, because that is very important. In order to prevent the degeneration, the meniscus root should be intact. That is very important. And if the root is ruptured, then you will see that it's almost equivalent to like, or almost 70% of total meniscectomy, where you have your weight-bearing surface is very badly damaged and they end up in joint degeneration. In order to prevent that only, we are trying to do a root repair. That only occurs if the degeneration is not there. The degeneration is already present, what to do? That's what the question raised earlier. And that's a scenario where you think about meniscus root tears. They occur in two patterns. One is acute tear. I think I hardly see acute tears myself. Those who are coming with ACL tear and along with the root tear of the lateral meniscus, sometimes we see, and those we repair it very nicely and they heal up very well. And most of them we see is a degenerative tear, which is subacute tear, and more commonly seen in patients coming with around grade 3 or 4 OA. That is more common. I think I would say about 70 to 80% of root tears are almost degenerate tears, and remaining 20 to 30% of the acute tears. And the rough algorithm for that is, if you have a root tear, those who are having arthritis anything more than grade 3 or more, then they certainly you think about conservative management, or if you think of surgical intervention, it's going to be HTO or unicondylar knee replacement. Only in those patients who are acute, less than 45 years, then I think about repair. All others, you should think about other options, or you can think about repair plus doing osteotomy also together. I think Manjunath was asking about that question, whether to do repair in a degenerate knee. That is a very debatable one. So what is the indication for HTO is degeneration should be in only in medial compartment, and the ligament function should be satisfactory, or at least to be to the reliable extent, or you should be able to do the ligament reconstruction all at the same time. And the FFD should not be anything more than 10 degrees, and there should not be any inflammatory arthritis, and the patient should be young. So young means in the sense is around 40 to 50, not like 20 to 30 I'm talking about. So I'm not going to go in detail about root repair technique, because that's out of my talk. So pull-out technique is the one which I do in those patients who need root repair along with HTO. So what is the surgical procedure that we are doing is, first thing is very important is you have to have an essential investigation. I do X-ray, scanogram and MRI for all the patients who are coming for HTO. That is compulsory for all those patients. And in the pre-op planning, you need to know about the mechanical axis and anatomical axis. And what we are trying to achieve is to do slight over correction, which means our weight bearing axis normally is in the center. We are going to shift it slightly laterally, which is our point is about 62.5% of the lateral side, which is from the medial side. If we calculate about 62.5%, still lie just lateral to the lateral tibial spine. That's where our new weight bearing point should be. So you draw an axis towards center of femoral head from that line, and the center of the tibia ankle from the distally from the tibia. So whatever the angle that you are encoding is called alpha angle. That is the angle that you need correction. That's a simple way of doing. That's what I do it. And for example, as you see, this patient who has got a varus knee left side is only a 43-year-old chap, and mechanical axis is way behind the way towards the medial side from the midline, and typical MRI will show a bone bruise, and the meniscus will be extruded, as you can see in this, and there will be joint space narrowing. And what I do is do an alpha angle like this, and whatever the alpha angle comes up, that's going to be my degree of correction for that particular patient. Usually, the patients who are coming around are like between 5 degree and about 11 or 12 degree varus. Beyond that varus deformity, you should not be thinking about HTO, because that procedure may not work and it might fail. So if alpha angle comes as 10 degree, then it roughly means it needs to be 10 mm of opening on the medial side. I'm only going to talk about open wedge high tibial osteotomy, not the closing wedge. So the instruments that you need are these special instruments, which are, you need those spreaders for the osteotomy, laminar spreader and osteotomy wedge sizer. And with these instruments, you can do a nice job. And first step is make a vertical. The incision will not be anything more than about 1 or 2 centimeters beyond your graft incision for normal ACL. For the ACL, we are making a vertical incision. If you are making 4 centimeters, maybe about 6 centimeter incision is the one that you need for doing osteotomy, and it's about 4 to 5 centimeters below the joint line, approximately about 4.5 centimeters, where the pes answer insertion is there. From there, you start your entry point and try to focus it towards the head of the fibula. That's where your focus should be, to put your guide wire first. And then you are doing an osteotomy. For osteotomy, you should have these stack osteotomes, where you have come with various width, we try to stack one over the other so that slowly it opens up immediately, and without breaking the lateral cortex, you try to avoid and do it. You should try to do that one. And there is a nice spreader which is available in the set, with which you can actually try to slowly expand the osteotomy site without breaking the lateral cortex. Whatever the degree that you want, for example, if you want 10-degree correction, then you should put 10 mm. Slowly, you have to increase up to 10 mm space for the medial side. Once you have done that, you can introduce that osteotomy wedge sizer, and you can actually graduate to about the desired angle of correction, desired millimeter of correction. And once you have done that, you can see that you can actually introduce this Bidu plate. This Bidu plate has got a approximately 2-hole distally. With the wedge kept open with the osteotomy wedge sizer, you can put that plate behind and you can start fixing the plate approximately distally. And this one has got advantage of having a wedge in between so that it won't collapse at all. Another option is using a tomo-fixed plate where you rely on the locking plates. This is not a locking design. As you can see that the plate has been fixed over here. And the typical X-ray will look like this, where you see that wedge is seated in between the medial side. This patient has got a 10 mm wedge. Once I've done that, I usually put a bone substitute to fill up the gap so that to ensure the bone formation. There are also papers which have shown that without even bone substitute also you can have bone formation, but that's more applicable for the tomo-fixed plate. But for the Bidu plate, it is a less, it's a tensile design, so better to have a bone substitute on top of the fixation. You can see that in 4 months post-op, the patient will have almost full range of movement. The good thing I like about most of the patients coming to HUA, they get almost full range of flexion. As you can see, another patient who is 6 months post-op, he is able to bend the knee almost fully, and he is able to cross leg, he is able to squat, which is not possible if you do a knee replacement. In majority of the patients, you won't get this kind of flexion in a knee replacement. That is a big advantage in doing a HTO. And another patient showing is the more important thing what you need to know about it is this patient has got a 12.5 mm opening. You need to open it very gradually. If you do very fast, then you have to respect the viscoelasticity of the bone, because the bone tends to expand if you do it slowly and gradually. If you do haphazardly, that you will break the other cortex and the thing will become unstable. Then the Bidu plate is not the right design to put it if the lateral cortex is broken also. So as you can see that this patient has got 12.5 mm, where you have still kept the lateral wedge still intact. And another patient who has got another 10 mm correction from in the lateral side, where you can see the APN lateral view, where you have put the bone substitute also. This patient also had a root tear. This is a eldest patient which I have done so far. He's a 58-year-old with root tear, and where I have done HTO. There are some patients where I have done root tear repair as well as doing HTO together in selective patients, where you see that there's only grade 2 or 3 OA, then you go to root repair also and also do HTO. What to do if there is a ligament injury also? You can actually add up ACL deconstruction along with the root repair or HTO together. Here I have a lady where we have done a PCL plus HTO together, because this patient is a 45-year-old lady who has got a PCL avulsion fracture, which is almost 1 year old, with posterior sag and severe medial side degeneration, where I went in for doing a correction of the both medial side deformity as well as doing a PCL deconstruction at the same time. As you can see here, what you have to do, the tricky here is that you have to make sure that you might have to do osteotomy slightly lower than what you are doing normally, and your PCL screw will go on the proximal fragment. So you do all your tunnel work initially and then do the osteotomy, so that you will not have the tunnel and osteotomy site coinciding with each other. So you can avoid that by doing carefully. So as you can see in this over there, you have your graft on the proximal fragment, and the plate is also over there. So this is the post-op picture where you are doing osteotomy slightly the distal than normally you do about 4 to 5. Here you do about maybe 1 centimeter distal to what your normal conventional site is. That's where you have to do. So you can get almost a good range of movement. The patient who is having pain, now she is pain-free, and also has got reasonable flexion is there. This lady did not get full flexion. She got about 100-degree flexion, but she was happy that because he is pain-free. That's what she wanted anyway. What to do if there is medial OA and FFD? FFD is relatively sold as a contraindication for doing a high Tbl osteotomy, but there is a small FFD like less than 10 degrees, you can actually do a differential osteotomy. So you can do slightly keep less anterior space and more posterior, then you can do correction FFD also. Which will be like doing a posteromedial osteotomy, whereby you can actually expand space on the posteriorly as well as medially, so that you can correct FFD as well as correct the varus deformity also. Similarly, you can do for the other side also. Those who are having Pcl insufficiency, you can do that also. So our experience in over the last 2.5 years is 26 patients we have done. Age group between 36 to 59 she is now. She was 58 when she had the surgery. And male is to female is 7 male and 19 female, and pre of diagnosis of medial OA, root tear, ACL, all these patients are there. Out of which I have only taken the root tear patient because this talk is on root tear today. Root tear is only on 15 patients, where we have found only the female patients at 14. Only one was male. All patients had grade 3 or 4 OA. Mean pre of virus deformed is 5 to 11 degrees. Joint pain is the predominant, and that's the reason for doing the procedure. I corrected 7.5 mm to 12.5 mm in most of the patients. 12.5 is 3 patients, 7.5 for 2 patients, and 10 mm for about 10 patients. 3 patients had root repair as well as HTO together, because I thought these patients have very less OA, and also the root substance was looking very nice. Then you can go on to repair also. If the substance looks very much damaged, or if there is meniscus look badly extruded, then I would avoid doing that. So in cases where you are doing isolated root repair, for example, not in the patient where you are doing HTO, I have done centralizations, where the patient should have grade 1 or 2 OA only, not anything more than. Then you can, where you look the knee looks virgin, then you can do root repair plus doing centralization also. There I think it works. In other cases, I have not done centralization because I feel in a degenerate knee, the purpose of doing the whole root repair is to prevent degeneration. If there is already degeneration, there is no point in doing all this. Instead, you should go on to HTO only. So post-op will be 6 weeks non-weight bearing, pars isometric and ROM from day 1 itself. Time to union in our patients is 14 weeks to 28, and the mean was 19.2 weeks. Mean follow-up now we have is 14.86 months, which is ranging from 4 to 32 months. 11 patients are fully satisfied, and 2 patients have mild pain occasionally but managing. 2 patients have slight FFT, but they're still managing. Post-op Vishom score got improved very well from 33 to 81. And 2 patients had a lateral cortex fracture, out of which 12.5 is one patient. Out of 3 patients who had 12.5 correction, 1 patient had a fracture. So it's not the end of the world if you have correction, you just have to do extra protection to the patient, and you can still manage it the same biduplate itself. And 1 patient I managed to change it to tomofix plate because I thought there is a locking plate, it has got better construct. So when I had a lateral fracture, I changed it to the tomofix plate. 1 patient had medial aspect numbness due to saphenous vein disturbance, and 2 patients had discharged post-operatively. Because these patients we are using bone substitute, some of them can get discharged. So you don't have to worry about, they are not infected, it will just settle down in 1 or 2 weeks time normally. So does root repair really heal? This is a nice interesting paper from Korea where they saw arthroscopically see whether the posterior root repairs are healing. Complete healing was not observed in these many patients. So even anyone who is having grade 3 or 4 OA, if we just do root repair, a lot of them don't do heal very well. So complete healing is not, incomplete healing was evidence in some patients. So remember this paper. And about open wedge high Tbl osteotomy, they have seen the healing potency where they have not even touched the root tear at all, not done repair at all. Out of some patients, 5 patients healed well. Complete healing was there, even without doing root repair. And remaining patients had lax healing, some of them had scar tissue. So what I'm saying is, even in HTO, isolated HTO, some of the patients, like not everyone, maybe about 20 to 30% will heal spontaneously. There is a possibility. But symptomatic improvement was there in many patients. If you go and see arthroscopically, you will see that the root tear has not healed, but symptomatically they were improved. Similarly, factors that are unfavorable for meniscus root repair are grade 3 for OA or chondral lesions. Varus deformed, anyone having more than 5 degree or obese patients are not good for doing root repair. I have 1 patient who was obese where I did root repair. She had trouble for many months and then I had to arthroscope and I found that root repair has not healed. And then I offered her HTO after a while and she got better after that. So remember, root repair is not a trouble-free surgery. Some patients can land up with trouble because root repairs may not heal if there is a degenerate condition. But it's a traumatic injury, it will heal. So does meniscus root tear heal after doing HTO? That is the one which I quoted you earlier. So the take-home message is high tbl osteotomy is indicated in patients with medial OA and root tear. Correction to be aimed for 3 to 5 degree valgus. So slightly to overcorrection. Too much overcorrection not advisable because that can end up in lateral side OA also. So outcome in this set of patients are satisfactory. Surgical technique is very important in order to avoid complication. Range of movement especially is very good. In compared to knee replacement, the range of movement usually you find out these patients have very good range of movement, except some of them might have 50, but majority of them will have a very good flexion. That's the good thing about HTO. Thank you very much. Any questions in the group?
Thank you, Dr. Subramanian. I think it's a very good talk. I just want to know, do you do something about the degenerated cartilage during your HTO, or you just leave that part?
Yeah. Very good question actually, Vinod, because at least I do microfracture.
Okay. That's...
So anyone having focal defect, mainly on the femoral side, you try to clear out all that area and do microfracture so that gives some advantage to the patient to see if they grow up some fibrocartilage. That is something I do. And in one patient, I have injected BMAC, and also another patient we have done inject just PRP, and some patients I have injected hyaluronic acid injection. So this is something I do routinely for majority of the patients. Hyaluronic acid is very common because it's not invasive. We just inject another drug inside the knee joint, which doesn't cause. I don't know whether how much it's effective, but I don't have any studies for that. But there are some papers which have shown hyaluronic acid has shown some good effect. But if you do in isolation, I don't think it is very effective. You have to do it along with the HTO. And it's very difficult to conclude whether it's HTO made the difference or hyaluronic acid. It's just additional one.
Very right.
Side effect, that's all.
Yes, agreed. Thank you.
Yeah. Any other questions? So if there are no more questions, shall we go to the next talk? Where I want Dr. Vinod, are you ready to do the share screen?
Yeah. Sure.
Technique of Pcl reconstruction. Pcl is always seen as a difficult surgery for younger trainees because we always fear about posterior capsule and vessel damage. But in a trained hand, it's actually a very simple procedure. And Vinod is going to demonstrate about his own technique and his view about Pcl reconstruction. Vinod, you please go ahead.
Yes. Thank you, Dr. Subramanian. And it's really, I'm thankful to you and organizers to share my views on this. And because the topic allotted to me by Dr. Subramanian is just the technique, current technique, how I'm doing. So I'm just going to share my current technique with you, and I hope may help to the youngsters to know a few things and can be helpful for their day-to-day practice. So as we know that this PCL is actually different from ACL in many ways. That first of all is that it's probably the strongest ligament of the knee joint, and it's really a bigger, thicker than ACL. So it's actually the core stabilizer of the knee joint against posterior subluxation. And second important thing is that PCL being the stronger one hardly get injured alone. So generally this PCL injury is part of the multi-ligament injuries, and in early stage generally these injuries tend to be missed by the youngsters, and that become one of the most common cause for the failure of the PCL reconstruction. If we are not going to take care of all the associated injuries, which may be LCL and PLC, MCL or other menisci, then probably the results will not be optimal. So once there is a grade 3 PCL, you must clinically examine in detail and see the investigation in detail and make the diagnosis holistically to include all the ligament injury which are there. And third important thing is the footprint, this footprint on the femur side is really big one. So there is a huge area which is covered by the footprint of the PCL on the medial femoral condyle, and it's basically made of, although by a big area, but primarily in anterolateral and posteromedial bundle. This anterolateral bundle is bigger, and a posteromedial is a relatively smaller one. Now, as most of us are already aware that the traditional technique is basically the standard technique, that is the Trans-Tibial Pcl Deconstruction, where you make the tunnel in the tibia, which goes a long way from anterior to the back, and we make a whole tunnel in the on the femur side. So this is the Trans-Tibial technique, which is most commonly done. And but this technique has certain problems which we have to understand. That first is, this is very invasive, and long tunnels are being prepared. And the problem by these long tunnels may be because it's a part of multi-ligament injury most of the time. So the tunnel convergence remains a problem once you have to manage a multi-ligament injury. And second important problem is the killer turn, that this basically the posterior exit and this curve make a very sharp turn, so that gives a difficulty in passing the graft, as well as it continuously remains a source of stress during flexion and extension, and chances of secondary lengthening of the graft remains. And third problem is that it requires, because long tunnels, so the longer grafts are required, which itself may be a problem mainly in the multi-ligament setup. So considering all these problems, the future evolutions were there. And the next important technique which was evolved was the Tbl Inlay Technique, where you put the bony plug of the patellar graft on the surface of the tibia at the back side at the footprint. It takes care of the killer turn up to certain extent, and probably it helps in a better healing. However, the problem still remains by this technique, that most of the time it's an open technique, because it's very difficult to make screws and plugs posteriorly by arthroscopy. However, the arthroscopy techniques are also described, but that is a very expert job, not so easy, and chances of neurovascular structures may remain. Secondly, the limitation of this is that this only is possible with the bone plug. So the graft, soft tissue grafts cannot be used. And in India, we don't have the allografts like the stendo-Achilles tendon and all. So generally, you have to be based on the patellar tendon or quadriceps patellar tendon, which may not be always available or choice of the graft by many of us. Now, after these two techniques, there are few recent developments which have occurred in the last couple of years, which have made certain modifications. And these two things are that one is this endo button, which we were using, is now variable loop buttons. These buttons have been there with the loop, which you can adjust the length. And by this device, you can control the length of the graft or fixation of the graft even after provisional fixation. And second important development is a reverse cutter or retro cutters or flip cutters, where you can rim from in a retro way, and it's not a need to go throughout the bone, and you can convert the tunnels into sockets. So by these two developments, we can go with the all inside techniques, which is a very commonly now done for ACL, and now is also possible and done in PCL. So what I usually do nowadays is basically I do arthroscopic conservative PCL Plasti using autogenous soft tissue graft by all inside technique. So what are the merits of this is that this all inside technique, you provide a good fixation on both side cortical fixation by the buttons. These you can say the variable loop buttons on both sides. So cortical fixation is probably the strongest fixation. So that is here first part is of good fixation. Second important thing is that you avoid the long tunnels and you just use the sockets, which minimal length of 15 or 20 millimeter, which are required for healing of the graft. And these small sockets also take care of inadvertent tunnel convergence in a multi-ligament situation. So you just create sockets. And the fixation has to be done by variable loops, so you can control the final rigidity or fixation strength by adjusting the length even at the end of the fixation. And the most important advantage of this technique remains, especially in multi-ligament scenario, that you require a very small length of graft now. The graft which were just wasted in the inside the long tunnel of tibia are no more required. So this become a very conservative approach for PCL, mainly in the multi-ligament situation. Other advantage is that you can do the retrograde reaming with the flip cutter. So another complication which may occur in PCL is that neurovascular damage once you put a reamer over the guide wire. So sometime inadvertent migration of the guide wire may lead to posterior vessel damage. In these flip cutters or retro cutters, because you come posterior to anterior, so chances are very bleak that you may damage. So it's very safe in comparison of progressive drilling. And graft passing can also be done either through AM portal or through PM portal, which take care of killer turn, and it becomes easy to pass the graft by this technique. There are few biological improvisations which can also be done to take care of this PCL anatomy. And first, an important thing is that I preserve the remnant in case of PCL, because what I see most of the time, it is different again from ACL. ACL tends to get dissolved because it gets from femur side and it get absorbed most of the time. So remnant is not really there up to that extent. But in PCL cases, because PCL is a broad ligament and it has a capacity to heal, so it heals. It has a plastic lengthening and it heals. It looks like an intact PCL, which is legs. So it remains a vascular PCL remnant there. So I try to preserve that remnant how much it is possible. I'll show you in the video. This probably preservation helps in terms of providing a vascularity and early synovial cover to the graft, which may have a better healing effect. And secondly, because it's alive, so there is some nerves there. So proprioception probably also remains better, which helps in rehab of the patient. So remnant preservation is an important part in PCL, which should be done. So I today, in my current practice, I use the word Pcl Plasti more rather than reconstruction, where you have to debride and put new. Now, the choice of graft has shifted now from hamstrings to peroneus longus, because this again is a good source where you can get a good length as well as diameter, and the penalties are not so high. So it is a good graft for PCL. And sometime if even this peroneus is not available, then I also use this semity hamstrings, and I augment with the fiber tape. So this fiber tape augmentation gives a strong scaffold against the deformation of the graft, and also add in some diameter. So these few changes in the graft and remnant also have to be incorporated in the technique, and I use in my technique in current practice. So these are the reasons why I choose the peroneus, because it gives good length, good diameter, and the peroneus brevis can supplement its function as an everter. So there is hardly any major function loss. Now there are some recent articles also have come up in favor of that it's an acceptable choice for ligament reconstruction. And this is the technique how you have to take the graft. you just make a small around 2 to 3 centimeter incision around this lateral malleolus. You just give an incision, identify the tendons. You can deliver both peroneus longus as brevis together, identify the longus by the long belly, and then here you just suture them together at the just proximal to the retinaculum, and then you cut the peroneus longus proximal to that tie. So the distal part of the peroneus longus is attached with the peroneus brevis, so it preserves the function up to certain extent. And now after putting these sutures, you can use the open end tendon stripper and harvest this tendon easily, and it gives a good length of approximately 280 to 300 depending on the patient's height. And quadruplet tendon gives almost 10 or sometime 11 diameter, which is good for a PCL. I don't think the hamstring tendons can give that much sturdiness, diameter and length for PCL. So this is the video I'm going to share with you. So this is a young guy who is having a multi-ligament injury, posterior drawer and lateral side PLC with lateral meniscal tear. ACL also is partial tear, which you will see inside. So there is a ACL, which is looks lax. This bundle AM looks intact, but it is secondary laxity because of the posterior sag. Now the medial side is okay. Oh, sorry, I think it's just flipped. Yeah, I'm sorry, just I think I clicked, so it went through. Yeah, I'll just go a little bit fast forward. Yeah. So it's a medial side. Meniscus looks okay. Oh, I think the video is creating problem. The lateral side, see the meniscus, all peripheral torn and drive through is there. So I use the peroneus longus graft. The graft is prepared. You can use fiber wire along with the semi-T also if a patient is not giving consent for that. So finally it comes somewhere around 10 diameter, and important thing is that this even up to 70 or 75 mm length is enough by this technique. So that is the really the advantage of all inside technique, that you don't have to waste. I'm sorry, I think there is some problem with the video to flow. So we use here I'm sorry, I think it's the PCL footprint is being prepared. So I preserve the footprint and just make the entry by radio frequency and make the tunnel. I'm sorry, I think it's some problem is there. So you create the femoral tunnel, preserving the remnant, and you just rim around 20 millimeter. Total length is 40 millimeter. Then you create the posteromedial portal, and you visualize it through window 2, that is between femoral condyle and PCL. We use 2 windows between ACL and PCL is window 1, PCL and medial femoral condyle is window 2. You debride the posterior septum, you work posterior to the PCL footprint and put the jig through the window 1 and go at the back of the footprint and place the jig at least 12 to 15 mm down to the posterior tibial corner. And then you put a flip cutter of the required diameter, here it is 10, and then make a 20 to 25 mm socket in the tibia. And then you pass the passing wire, ethibond or fiber wire or ethisteel wire, and then take out this loop through window 1, that is important, between ACL and PCL. And then take both the loops. One loop is in the femoral tunnel, another this loop has passed. You have to take both the loops through the anteromedial portal out, and then load the femoral side of the graft on one end on the femoral side loop, and then pull this button, flip the button on the desired length, and then make the loop shorten, which will take the graft in the femoral tunnel. Now you pass the Weisinger rod through the posteromedial portal, and this make it a pulley over which you pull the tibial side, tibial end of the graft and pass it in the tibial socket. Then finally the graft is tightened on the femoral side variable loop. This is the advantage that you can adjust the final tension of the graft in 90-degree of this, and you can make the graft fully tight. So this lead the preservation of the remnant on both sides, and in center you can make the graft. So this makes the ACL laxity away. And I think it's a PL bundle tear, so I have to do PL augmentation as well as lateral posterolateral corner repair and lateral meniscus repair. I'm sorry, actually there's some video problem. It could not go through clearly. I don't know how much it could help, but this is a good technique which we can practice. I'm sorry, I think some technical issue. So this looks like a good PCL. Finally, you can evaluate and do the other parts, reconstructions and repair. So still there are some drawbacks that the high level of expertise is required. Definitely, you have to really deal with these new gadgets, and length of the graft is critical to prevent bottoming. If your length of graft is more than the length of the both socket and intra-articular length, then you cannot achieve the desired tension. So you have to add towards more length of the socket plus intra-articular than the graft. So too long graft should not be prepared, and flip cutter sometime may break, leading to incomplete tunnel or socket formations may be there. And we have published this one article in Journal of Arthroscopy Surgery, that how you should take care of these broken flip cutter, how you should avoid. And definitely these equipments and jigs are required for this technique, which are available with Arthrex in today's time, and probably some other companies are also in the market. So I think that completes this technique. So thank you to all of you. And I'm sorry, actually, I don't know why this this could not work. I have this video separate. I don't know the time permit. Otherwise, I could show that. So that completes the talk. Thank you to all of you for your patience listening. Thank you.
Thank you, Dr. Vinod. It's a nice technique. I enjoyed seeing that.
Yes, thank you.
Any questions from the? I think there are some question and answer. Excellent technique with strong reasoning. Is there any downside in this technique which needs further improvement? Question is from one of the audience. Is there any downside in this technique which needs further improvement?
Yeah, downside which I have already mentioned. These are the 2-3 drawbacks which are there. That this flip cutter may break if you are not using in a proper way. So actually these flip cutters are sensitive at the tip. So the balance of rotation and pull have to be there. If you are pulling too hard without proper rotation, then this generally get break. So that is the one important thing. And other drawback which generally technically happen is that you prepare graft of 80 millimeter, you prepare short of 15-15. Now your length is less, and you have passed the graft, it is less. And now your tunnel, because these are the sockets, so it's already bottom out, and then you cannot make the graft tight. And then you get stuck. You have done whole procedure, but your graft is not desirably tight. So you lose the whole merit. So this exactly you have to take care that your graft length should always be shorter than the combined length of both the sockets. Plus for PCL, you take around 35 to 40 millimeter. So for an example, if I have a 70 long graft, then you should consider around 35 to 40 or take 40 for intra-articular length of PCL. Then you prepare at least 20 and 20 on both sides. So 20, 20, 40. And then if it is 35, still it will be 75. So that you should calculate exactly. Socket, there is no harm to make even 25 on the TBL side, but never make it too small. Otherwise you may come under trouble. So these two are the main, I think, problems with this. Other than that you require the special jig and that flip cutters with your armamentarium.
I think I totally agree with what you say. That is the only problem that can occur if there is a length mismatch. And it is possible in ACL or PCL, whatever, whichever technique that you are using. You're doing all inside technique, your combined length should be shorter than the whole length of the bone.
So that is the main, I think, technical problem which happens.
There is one more question in the chat box. What to do when on tightening variable loop breaks? I have never had variable loop breaking, but have you ever had the situation, variable loop breaking?
Yeah, you see, I have it in basically ACL, not in PCL. In ACL, I do generally trialing technique. So trialing, I use the means 2 femoral socket and 1 TBL. So on that side, I use a AM bundle is triplicate semi-T, and on PL is just a double semi-T. So this is a one, I think is a good question, because if it is just a double graft or the tendon is weak, this device has a very, very strong, you can say the power to pull. So rather than the loop never break, actually it break the tendon. What happened in my practice once is that it came through
Yes,
breaking
right.
the graft. Actually,
Yeah,
loop
it
is
cuts
so
the
strong, it cannot break. But then
Yeah.
again, it is a problem. You have the whole button comes in your hand, and now the loop is there inside. So it actually is a difficult situation. And in that situation, you can, if still the tension is adequate, I think only way is that you can fix it by some screw on the aperture side through inside. Otherwise, you have to revise. I don't think there is any third solution for that problem.
Correct. That loop does not break at all. Never.
Yeah, loop does not break, but it can come out
Cut through.
through the loop. Cut through of graft may happen if you are overzealous. So
Yeah.
that you should not do over tightening by this technique.
In what position of the knee you tension the graft? Is it different in all in C technique? I think it's no different, isn't it?
No, it's not different because I mainly focus on the AL bundle. So I fix it in 80 to 90 degree of flexion. That is the key position for PCL.
Yeah. Fine. I think nice discussion also.
Yes.
Thank
So
you.
Thank you. Thank you. Thank you, Dr.
Can't
Subramanian.
see any more questions in the chat box.
Thank you.
If there are no more questions, then we'll proceed on to the next talk. And I request Dr. Manjunath to share his screen to tell his view about patella instability and middle patellofemoral reconstruction.
Thank you, Dr. Vinod, sir.
Manjunath, share your screen.
Yeah.
Please go ahead.
Good evening, everybody. Today I'm going to talk on Mpfl reconstruction. Patellofemoral instability is common due to anatomical abnormalities of the bone, incongruence of the trochlea or the patella, or to the alignment changes, or to the genu valgum, or due to the insufficient soft tissue restraints. Dislocation is a result of anatomical soft tissue restraints. Non-surgical approaches have been advocated to treat acute patellar dislocation, but most of the operative procedures are for the chronic or recurrent patellar dislocation. They include soft tissue or distal realignment procedures. So addressing the specific anatomy, the biomechanics, taking proper history, physical examination, and the radiographic interpretation can shed important light on the treatment options of recurrent patellar dislocation subluxation. So coming to the basic anatomy, so in patellofemoral instability, we have this passive stabilizers and the dynamic stabilizers. Passive stabilizers being the trochlear groove and the patella, their congruity, which engages the patella, which avoids the instability. And the topic of interest of today is Mpfl, that is the primary static soft tissue stabilizer, which contributes more than 70 to 80% in the stabilizing contribution of the soft tissue element for the patellofemoral instability. The dynamic stabilizer is quadriceps VM. So what are the pathological anatomy leading to the patellar dislocation? So there we have primary instability factors and the secondary instability factors. Primary instability factors being trochlear dysplasia, the patella malposition, patella alta, and the patella baja, patella tilt, and the TTTG distance, which is the quantification done by CT scan. And the secondary instability factors being extensive external femoral internal rotation or Tbl rotation, and the genu valgum or the recurvature. So who tends to have more of patellofemoral instability? Commonly seen in men. Females are mostly seen in non-athlete gender. Females are more commonly seen. And say traumatic disorder and anatomical abnormalities can contribute, as discussed in the earlier discussion. So evaluation, we have to evaluate completely the integrity of the medial patellofemoral ligament and the patellar position has to be evaluated with the radiographs taken with AP and lateral view to assess the patella position. So the knee, we have to take the Q angle, and then CT has to be done to assess the TT to the ratio. And then MRI, even though we take an axial at the stylier view to assess the patellofemoral congruity, sometimes the bony congruity might be there, but the cartilage may not be like in the same depth surface. So we need to get an MRI so that you give a better idea of patellofemoral congruity. So this is a simple algorithm to help us to decide about the procedure. So if the patellar instability, if there is any subluxation, the first treatment of choice in patellar instability is conservative treatment. If there is a failure of conservative treatment, then we'll go with Mpfl reconstruction. And if there is any dislocation, it depends whether it is acute or recurrent. Acute dislocation, we'll assess whether it is osteochondral fracture, go do arthroscopy. So do the needed procedure. No osteochondral fracture, it's a young athletic patient with predisposing factors, you could go ahead with Mpfl repair. And if the injury is to the direct mechanism without predisposing factors, we'll give a trial of rehabilitation, and if unsuccessful, go ahead with Mpfl repair. In the recurrent dislocation, it is Mpfl reconstruction. So understanding the brief anatomy of Mpfl is very important. So it is nothing but a thickened medial patellar retinaculum in the superior medial part. The attachment on the patella extends into the proximal lobe, moving on to the quadriceps apparatus, and the attachment on the femoral condyle is very important for us. So there it will be like in comparison to the medial epicondyle, it is 10 mm proximal and 2 mm posterior. In comparison to the adductor tubercle, it is 4 mm distal and 2 mm anterior. So width of Mpfl at the femoral insertion is around 10 mm. So whether to repair or reconstruct. Acute repair, we have mixed results. Only 20% failure rate is there. In acute repair, it's better to have internal bracing. The same way how we do Mpfl reconstruction, instead of graft, we can use a fiber tape in the position, and we can give more stability for the repair so that the failure chances is less. Late repair, there is high failure rate. So always Mpfl reconstruction is advisable in late cases, chronic cases. So what are the ideal candidates? So I got a less than 25 degree Q angle, no cartilage lesion, trochlear morphology with a de jure classification, normal or type A, and the TTTG angle if it is less than 20 mm, and no patellar malformation, and the patellar tilt is less than 20 degrees. So basically, there should not be any other associated abnormalities, so that we can have a better result with Mpfl reconstruction. Or it can be done in adjunct to the other procedures like Pcl Plasti, distal relevant procedure, or BFO. Contraindications. So the main thing we need to understand here is Mpfl is not meant to pull the patella into the position. Its role is to stabilize a located patella against excessive lateral force. So we should be very careful in selecting the cases for the procedure. So we have to differentiate what exactly is the instability. So isolated patellofemoral pain should not be confused that it is due to the lateral translation, and then you should not go ahead with the repair. Or if there is any excessive lateral femoral tilt or translation imaging, and if there is no evidence of recurrent patellar dislocation, you should not go ahead and do Mpfl reconstruction. And as discussed in the earlier slides, if there is significant patellar malalignment with increased Q angle or trochlear dysplasia, or if you see any patellofemoral degenerative changes, Mpfl is not advised. So coming to the surgical steps. So examination under anesthesia, for all cases I do like diagnostic arthroscopy to assess the cartilage part and to have a prior knowledge how it is articulating with the trochlea, patella, how it is sliding over the trochlea. And we have this graft harvesting preparation. I will explain in the next slides. Graft source depends. I always prefer the gracilis tendon. One is stiffness closer to Mpfl, and the smaller tendon I need not worry about the reducing the size, or while I use the suture anchors to anchor to the patella. So gracilis is ideal to anchor it for me. So we can take medial patellar tendon, adductor tendon, or quadriceps, depending on the surgeon choice. The tendon graft, fixing the graft to the patella, like various surgeons use various criteria. So first, the one is tunnel graft, where the longitudinal tunnels are used, so that graft passes through the medial facet, comes out from the lateral end, and forms a loop and comes out the exit through the other tunnel. Or suture anchors, which I commonly use. Or some surgeons use this graft anchoring coming out through the anterior. So we have this, in these cases, we have this patellar tilt, so not advisable. So fixation of the patella, we have this drill holes like either longitudinal or the transverse holes, and anchoring depending on the screws or the end of button. And in some cases, we have this suture basket view technology or formigate rough. So these are the incisions. This is normal standard hamstring incision which we take to harvest the graft, but we can use this preferred hamstring incision very close to the femoral attachment instead of going to the anteriorly, depending on the surgeon's preference. So standard technique of graft harvesting, which we are all aware, and patella preparation, taking the incision here. And then this is one technique where the graft is passed through the tunnel. The longitudinal through and through tunnels are done, and it is looped, and two ends of the graft are coming out, and next planning to be fixed. So after taking the graft from the tunnel, a soft tissue tunnel is made between the medium retinaculum and the giant capsule outside this thing, and then an incision has been taken near the middle glandular adductor tubercle for the insertion. Fixing the graft to the middle epicondyle, near to the middle epicondyle of the femur, the exact location is very technical and very important in Mpfl reconstruction. This is another surgical technique which I do regularly. Is the gracilis tendon harvested, the ends are prepared, and they are drilled into the patella, and they are anchored with suture anchors, ligament fixing anchors, and fixed to the femur. So we have the guide also. So normally what I do, the first guide one, which is the lower one, is taken at the middle of the patella, and 1 centimeter from there superiorly the anterior guide wire is passed. So using jig will make sure that we are in the parallel to the patella, and we should make sure that the control surface should not be damaged. And the disadvantage of longitudinal, which I am going to explain in the future slides, is there might be a risk of patella fracture. So always use to drill only 25 mm of the tunnel, so that through and through tunnels are not done in the patella, so that the risk of patella fracture is avoided. Important one, the fixation of the femur is either done with various modalities, either with interference screw, a suture, or bone plug staple. The important point which I discussed in the anatomy of the Mpfl ligament is the position of the fixation of the graft on the femoral condyle, which is very crucial in this, which I explained already, that in respect to the middle femoral epicondyle and to the adductor tubercle. Using fluoroscopy will make it more accurate. We have to take a true lateral view. If femoral tunnel is not properly fixed, if it is too far proximally, may lead to graft laxity and extension and excessive graft tension infection, which manifests clinically as anterior knee pain and loss of flexion. If tunnel is placed too far distally, we'll have a similar clinical result because of excessive graft tension in extension rather than flexion. So we have got scrotal point, so which guides us in the fluoroscopy to locate the exact fixation point at the femoral condyle. So we have got two lines drawn perpendicular to the first line is drawn distally from the posterior femoral cortex, And then two lines are drawn perpendicular, one intersecting at the point where margin of the medial condyle meets the posterior cortex, and the second intersecting the most posterior part of the lumen spline. A 5 mm diameter of circle is drawn. So this is made easier with commercially available guides. So using this guide with the fluoroscopy guidance, we can exactly locate the point of insertion on the medial condyle of the femur. So after locating this point, so we have to pass a guide over that point and to assess whether we are at the right point or not. That is isometry of the graft, because tensioning of the graft, having equal tension on both sides is very important. So we have to pass a guide where loop the graft around that, and you can do the cycling, and you can just assess whether it is right or not. Then you can drill. That's very crucial, because once you drill, then it is you have very narrow space there. There is no scope for adjustment. So place the pin at the scrotum point, drill to the lateral side, and then 4 mm tunnel has to be drilled, and next, depending on your graft size, you can drill. Okay. So the important point is passing a retinal wire after passing the guide pin, after looping the graft into the tunnel. Before pushing the graft completely, you pass a retinal wire for screw insertion, because once you put the graft completely, it will be very difficult to negotiate and find the tunnel. So it's always advisable, before putting all the graft into the tunnel, put a retinal wire for the screw insertion. So appropriate tensioning is very important. Ideal tension is at the time of the booking, it's unknown, but we need to maintain it. They have pull both the tendons and the tendons accurately and then maintain it. So we have to fix at 30 to 40 degree of knee flexion. So in the initial part of when we are doing in the early learning curve, it's always while tensioning whatever the graft, whether it's ACL or PCL, we tend to tighten very harder. So that should be avoided. We should be very careful, because the margin of error at Mpfl is very less. So over tightening should not happen. So what ideally I do is the lateral border of the patella, I keep it at 30 to 40 degree flexion, we kept in line with lateral border of the trochlea. So and then graft is tension at that point of time. So when I extend it, I should have at least 1 or 2 quadrant of patella, at least that is 1 centimeter patella, rolling onto the lateral side. So it should not be too tight. As I said, Mpfl is more of a stabilizer rather than pulling that. So over tightening, if you do, it will lead to the medial patellofemoral tightness, causing the anterior knee pain. So lateral tension beyond the lateral muscle should be avoided. Excessive tension in flexion can lead to painful restriction of the knee flexion and the articular cartilage overload on the medial patellofemoral compartment. So once I do Mpfl reconstruction, again I do arthroscopy and visualize through the superlateral portal, so to know the patellofemoral tracking to assess it. So which will make you confirm that you have done the right job. Rehabilitation, normally I mobilize them for first 2 weeks strict immobilization, and then allow them to go for weight bearing completely in knee complete extension, and then allow range of motion after 2 weeks from 0 to 6 degrees. Weight bearing is allowed depending on the pain, from minimal to full weight bearing depending on the pain. So from 4 to 6 weeks onwards, I will allow them without knee brace. So closed clientic chain exercises between 3 to 6 weeks, open exercises and strengthening from 3 to 6 months. So return to the contact sports from 4 to 6 months. So next, the complications which inevitable. One is due to the position where we are highly inverted medial aspect of the knee is intervened, so that will have some numbness or pain, and then immediate adhesion formation or persisting loss of flexion will be there. And if proper positioning is not done, we'll have patellofemoral pain and anterior knee pain will be there. So if there is any stiffness, it's advisable to go for manual manipulation. So regular other complications are promulgation of the fixation hardware, other patellar fracture in case of longitudinal tunnels taken through and through or incorrectly placed tunnels. So that may lead to recurrent collateral patellar dislocation and other routine complications like infection, hematoma, papilloma. Thank you.
Thank you, Manjunath. It's a concise overview of what you gave. Any questions? So, which is the preferred technique for you? You don't do trans.
I don't do trans-patellar. I preferably use ligament anchors, securing like double tendon, like securing the graft with ligament anchors on the pedal side and then pulling out. You use loop insert, you use longitudinal tunnels and then you do looping.
I know there is a history of fracture with trans tunneling.
Okay.
But I have done for many years actually.
Okay.
People through, touch wood, so far I have not had fracture, but I can have it at any time. But the technique I do is use that spade drill.
Okay.
We have it in the spade drill you use, that's only 4 mm. And the graft size is 4 mm only. And try to make it into different planes. Start one from, the starting point will be same for both.
Okay.
But the exit point will be slightly different. So one will come superior anterior, another will go inferior posteriorly. They will have a slightly wider gap in between. That's what I have done so far.
Less stress rating.
It won't go to the other cortex totally. It will come to the post anterolateral like that.
Okay.
So that it will not go through the full and full of bone. And that's the way I have done. So, and that should have not had any. That's only the most important thing, cost cutting, isn't it? There's no cost involved in when you're doing a trans tunnel through the bone.
Exactly. We need only.
All those are expensive procedures. That's why.
Exactly. And then in skeletal immature patients, have less experience in skeletal immature patients. Sir, what do you prefer in skeletal immature patients with patellar instability, sir?
For patella, no difference. Same. For the femoral side, I use Siam and do the same starting point, but you direct it slightly proximally and anteriorly. Given the growth plate.
Fine.
Vinod, what is your view on this? Do you routinely use shuttle point, or you use conventional technique, or you use shuttle point? What do you do?
Initially, I was using actually this radiology and all, but now I don't use that frequently and use just based on the insertion of the adductor magnus and then do it. Yeah. And technique on patella side, I agree that these sutures are luxury. So if patient can afford, definitely they are good for surgeon friendly, easy, but definitely cost is a problem. Once cost is there, then we have to come into that what Dr. Subramanian has told. I also do that. So it depends on this financial status of the patient many times. Only thing is I want to understand from you that how do you decide the exact tension? Still sometime even with the best of precaution, in few patients it disturbs me sometime. So how exactly you decide? Is there some trick for that on table?
On table, one thing is like I maintain in 30-degree flexion that I follow the lateral border of the patella is in line with the lateral border of the trochlea. So that initially what I used to err, like being more aggressive in the tightening. Now I will say that, okay, fine. If I err on less, the tensioning is always better. So that the chances of dislocation is very less rather than patient having one more problem after getting the procedure, anterior knee pain and all. It's always advisable to go.
Definitely. Okay, thank you.
Okay, thank you.
Similarly, the Shortle's point, I used to do with the X-ray in the past.
Okay.
And there are a lot of errors in the Shortle's point also when you do with the X-ray.
Yeah.
You have to perfectly have that. I actually checked myself. I started doing without Shortle's point now. And my conventional point and Shortle's point is not very much different if you see in the X-ray. So I stopped using Shortle's point nowadays. I'm not using it at all. And if you're not using the true lateral in Shortle's point,
that's it.
you will have a gross error.
Agreed. Fully agreed.
Be very careful
Uh,
with the X-ray. Yeah.
As Vinod sir has told, I think between adductor tubular medial epicondyle go for the tendon insertion, and then you come somewhere in between rather than relying completely on the radiography, which can vary with the position of the limb. Again, if it is not true lateral, we can err on that.
Yeah. I think I just see the question answer box. So I think there's nothing more there, as you can see. All have been answered. So if there is none more, I think we are coming to the conclusion then.
Yeah, yes, thank you.
Yeah. But it's
It's
a
a
little
good
long
session.
for
Yeah.
us today. We are supposed to finish by 9, but we are almost
And
Saturday night
And,
managing.
yeah.
But I have to give thanks to yourself, Dr. Manjunath, Dr. Vinod, and I think Angus has left. I think, yeah, Dr. Angus Robertson and
Yeah,
whole
yeah.
Biotek team for organizing this. I think at some point we saw almost 60 people are attending the participants.
Yeah, yes.
Some panelists were there and attendees were there, and hopefully some of them will watch through the YouTube. It
Yeah.
gets uploaded tomorrow, day after tomorrow. It gets uploaded. So thank you very much for giving us opportunity to serve you. Thank you.
Thank you. Thank you to all of you. Thank you. Thank you.
thank you.
Thank you, sir.
Thank you.
Good evening to all. My name is Kathy, and on behalf of Biotek, I would like to thank you all for giving us your precious time and for this wonderful webinar. And special thank to Dr. Subramanian for initiating this wonderful webinar. Thank you so much, sir. And
Thank you. Thank you.
Thank you.
thank you, Dr. Angus also, Dr. Vinod Kumar, and Dr. Manjunath. Thank you so much.
Thank you, ma'am. Okay. Bye-bye.
Thank you
Bye.
very much. Have a nice weekend. Thank you. Bye.
Yes, thank you.
Thank you, sir.
Okay, I'll leave the meeting. Thank you.
Yes.